This is Mary Sir with M2 Revenue. This is part 3 of a 4-part series on optimizing revenue through capturing nurse work, and this particular series is on care management. Let's get started. This slide shows the 3 main types of care management codes available currently, one new even as of this year. There's principal care management, chronic care management, and complex chronic care management, and we'll go through each of these columns individually. Principal care management is the code new for this year, and I think it is a significant add to the CPT code set from the AMA. This is for a single complex condition expected to last 3 or more months that puts the patient at risk of hospitalization or functional decline. What you need to do is create or adjust a care plan, and then you have to document your time spent per month. There is a CPT code set for staff, which is your nursing staff, in managing this plan, and there's a CPT code set for physicians and APPs in managing this plan each month, and you can see the RVUs at the bottom. Chronic care management is the oldest of these codes, and it is a patient who has 2 or more chronic illnesses for a year or more that place the patient at risk of death or functional decline. So again, you have to create a plan of care, and you have to document your time spent per month. The difference between this and principal care management is the number of diagnoses that you're managing, the number of illnesses, and also the time set, which is a little bit strange. I'm not sure why they did this, but for the physicians and APPs, there is a time code set for 20 minutes instead of 30. And then for the staff, for the nursing staff, the code set starts at 30 minutes. And then you can see the associated RVUs. For complex chronic care management, it's the same as chronic care management, but the concept is that there's always a high level of decision making. There are frequent interventions, multiple medications, need for admissions and caregivers. So it's really thinking about how sick your patient is. There's several sites that recommend doing a matrix or some kind of criteria for when a patient would fit complex chronic care versus chronic care. But you can probably think of patients that really do require this level of work that fit this definition. Again, you have to create a plan of care and document your time spent per month. This code set is a little bit different, though. It talks about care directed by a physician, so it's not thinking about time personally spent by staff or a physician. It's thinking about all the care that's directed by a physician but can be communicated by anyone. So there's a code for the first 60 minutes and a code for each additional 30 minutes. You can see the RVUs in the last cell, but you can see that this is a little bit different concept. It's almost like our critical care concept, that this patient needs so much care that there's any number of people that are going to be communicating it. It's just all going to be directed by a physician. So what is a comprehensive care plan? This bulleted list is what CMS outlines as part of a care plan. Obviously, it doesn't have to have every bullet, but you can see the level of detail that needs to be included. The expectation is that you're going to create an initial plan of care, almost like a kickoff visit with the patient, and give them this plan of care. And then each subsequent month, you're going to make adjustments to the plan of care. So obviously, there's a problem list. There's the expected outcomes and prognoses, measurable treatment goals, symptom management, plan interventions, and identify the individuals who are responsible for the interventions, medication management, community and social services ordered, a description of how services of agencies and specialists outside of the practice are directed, and then a schedule for periodic review and revision of the care plan. And this can also include a schedule of physiologic and or therapeutic monitoring, which is another code set. So it's very comprehensive. That's the whole goal, is to manage care so that you can reduce the number of admissions and emergency visits, but it's something that you're probably doing for your patients anyways. It just may not be formalized. Some other things that CMS outlines for care management programs are that the primary person, the person delivering this principal care management or the complex care management, also monitors that preventative services are received. I think the assumption is if you have one of these diagnoses that the specialist becomes almost the primary caregiver and one who's coordinating all the services, but just to make sure that the patient gets preventative services. Only one provider can bill this code per month. So if it's identified that you are the care plan manager, then that's the person who would be billing the code each month. The patient needs 24/7 access to care. Usually that's available anyways through a call service or on call or through a hospital affiliation, so that probably would not be a barrier to starting a program. Again, the goal is to reduce hospitalizations and improve patient outcomes. And then I mentioned this in the last slide, but you can also bill for physiological and therapeutic monitoring separately as long as the time is split out. And we're going to go over that in detail in part 4. The purpose of the series is to show how nurses can help optimize revenue. So in this scenario, it's how can nurses help your care management program? And again, I think this is an opportunity for nurses to step into leadership roles and really become engaged with their work. The nurses can create marketing tools and help market the service to patients. I think it is a really great thing to say that we have a care management program for very common diagnoses that you're managing and doing all of this work anyways, but really formalizing it, making it attractive to patients. The nurses can update and manage the documentation requirements with oversight from the physician. So remember that there's a new rule that says anyone on the clinical team can document in the record now, as long as the physician or APP reviews and signs those notes. So you're looking at the requirements for a care plan and thinking they're kind of daunting. Your nurses can help you with that and make sure that all the elements are done. They can schedule monitoring and check-in calls with the patient, make sure that this plan is up and running, and they can keep up with time spent in documentation and help formalize the billing process each month. This slide has a lot of detail, but we're going to go through it piece by piece. This is an example of a patient that needs principal care management. The same concepts would apply for chronic care management and complex chronic care management. This patient is a 21-year-old female with uncontrolled type 2 diabetes with 2 admissions for DKA in the past year that needs a comprehensive care plan to manage her condition. So the patient consents to being part of a care management program due to her worsening status. The word consents is highlighted. We're going to talk about that in a little bit. Her care plan is created on 3/15 after a routine visit on 3/10. The total time spent in the care plan creation by the physician is 30 minutes. The total time spent by the nurse during a patient phone check-in on 3/27 is 30 minutes. The patient is instructed to send glucose readings every 2 weeks to the practice electronically. The patient sends the first download on April 1st, the second on April 15th. The physician spends 30 minutes reviewing the data and informs the nurse on how to revise the care plan for April given the readings. The nurse updates the care plan and spends 20 minutes relaying information to the patient on 4/20 for a total of 45 minutes of work in April by the nurse. The physician reviews and approves the documentation, but does not talk with the patient directly that month. So what is billable here? And the answer is a lot. So the numbers that I'm giving you are based off of CMS values and average reimbursement. Managed care would obviously be a lot higher than this. So you've got the E&M visit on 3/10. So that's going to be paid by everybody, hopefully billed by everybody. So that's $92 in reimbursement. Then the physician spent time creating this care plan. So that is $99424, an additional $83 reimbursement. And remember, you're probably doing this work anyways, it's just not formalized in the documentation, and that's where the nurse can help you. The nurse spent time on 3/27 relaying the care plan and following up with the patient, so that's an additional $63. The physician time reviewing the glucose numbers and revising the care plan in April is also billable, so that's another $56. And I'm sure that you guys are aware that you're doing that work anyways. You have to do in order for clinical care. It's just a matter of documenting it appropriately. And then there's the 45 minutes of nurse work on the care plan on 4/20 for April, and that's another $48. So if you aren't using a care plan program currently, you're really probably only billing the E&M, which is the $92. But if you do have a care plan that incorporates all of these things, and the odds are that you already do, you're just not documenting it correctly. If you had the care plan documented, it's $342 for that month. So you can see a significant difference in revenue by documenting these care plans appropriately. So that is you're digesting that last slide. You're thinking about diagnoses that you are already doing this work for and can really get a formalized plan started. So how do you get started? I did highlight the word consent in the previous slide, and it is absolutely critical for the service because of additional charges. The patient needs to be aware of what's happening so that if it does hit their deductible or they do have out-of-pocket expenses, they know what's going on. I would research reimbursement in your area and be prepared with payer information if the patient would like to participate in advance. It would be similar to a procedure or anything else that you're going to get pre-authorized and make the patient aware of. I would create a welcome packet. Again, this is a marketing tool, and do a kickoff of the program instead of starting to charge without communication, because as you guys know, that never goes well when the patient's not aware of what's happening if a new service is started. So make it part of a, again, marketing effort for your practice to see that you have care management plans for these common conditions. The kickoff should include acknowledgement of the nurse effort, an incentive for extra work, and additional documentation training. The nurses need to know how to document and how to help you, but they could be the heavy lifters of this program. You should track reimbursement, patient outcomes, and progress to include in future marketing efforts and the decisions to maintain the program. Not all payers reimburse this code. As we know, that's probably true of a lot of codes, but it is important to see how you're getting reimbursed and also how the patient's doing, if the concept of making this formalized has any kind of impact versus an informal structure. There are other types of billable care management codes out there. There are transitional care management codes, advanced care planning, psychiatric collaborative care, cognitive assessment and care planning, and physiological and therapeutic monitoring. That last one is going to be part 4 of our series, and it's really exciting how these codes are changing in the last year or two. I think care management plans could be a wonderful addition to almost any practice. I think it is a way that nurses can help not only patients, but help revenue for the practice. If there are questions, if you want to go through your particular specialty and think about your scenarios, feel free to send me an email, question@m2revenue.com. Thanks for watching.